So we have a set of panelists here today. The way the session is going to go is we'll have our panelists introduce themselves, and then we have a set of questions for them. And then if any of the attendees have specific questions, you can private message me and I can ask the panelists during our big Q&A panel. And then we can do breakout rooms depending on how much time is left. So if we could just have our wonderful panelists go ahead and introduce themselves.
I can get started. Assalamu alaikum. It's really nice to meet everyone virtually. My name is Dada. I'm a second year internal medicine resident, almost a third year. I'm at University of Michigan, and I'm applying for GI fellowship this summer. So yeah, I'm not sure, Dina, if there's anything else that you wanted us to talk about in introductions, but that's kind of a rundown about me.
That's perfect. Thank you.
Yeah, thank you.
Hey guys, I'm Yusuf. I apologize. I think it's kind of dark back here, but I'm a second year at Baylor College of Medicine. I'm almost going to be a third year, and I'll be applying to cardiology fellowships in a little bit, inshallah.
Awesome. Okay, so I'll get started with our first question, which is why did you choose internal medicine?
Oh, hi. Sorry.
Oh, we have one more.
I
Sorry.
forgot to introduce myself. I was just muted here. So, my name is Tasneem Imran. I'm a cardiologist and assistant professor of medicine cardiology at Brown.
Awesome. Okay. Awesome. So now we'll have the first question. Dr. Imran, if you want to start, why internal medicine?
So that's a good question. At one point when I was a student, I was between medicine and surgery, and I think they were both great. It's just what I really liked about medicine was that there's a thought process involved. We're really looking at everything holistically, and in particular, I really enjoyed cardiology because as a cardiologist, we're doing so many different things. So it really keeps you on your toes, and it's constantly changing. So I like doing procedures and imaging and seeing patients in the hospital and in the clinic. And the field is constantly evolving. So I'm always learning. So it never gets boring. So for me, it was a combination of all of those. I would love to hear what other people's experiences were.
Yeah, I think some of what Dr. Imran said definitely resonates with me as well. I think kind of the breadth and depth of medicine and just being able I remember one of my mentors when I was in medical school had talked about how she felt like as an internist you can walk into the hospital, and unless it's like a primary surgical issue, that you can definitely by the end of your training feel comfortable pretty much taking care of anybody in the hospital. So I felt like that was a nice way to think about internal medicine as a field that's very broad, and encompasses a lot of different pathologies and different types of patients that we get to interact with. So that was something that definitely drew me to the field initially. And I do think kind of the more intellectual pursuit is nice. I like our approach to rounding and kind of thinking about patients, and almost like a sense of mystery solving. I love when we have cases that are not very clear cut, and you and your team are just really putting your heads together with other consultants and trying to figure out what's going on, to ultimately kind of play a really significant role in patients' care. But I also personally am very drawn to kind of the more humanistic aspect of medicine too. And I think kind of our field's emphasis on kind of looking at things more broadly kind of goes hand in hand with that as well. So those are kind of some of my reasons for thinking about medicine.
Yeah, I'm just going to echo what Dr. Imran and Dal have been saying. I think for me personally, I was very fortunate in that I kind of liked every type of rotation I did in medical school, whether it was like surgery, psychiatry, neurology, that kind of good stuff. But what separated, I think, internal medicine from the rest was that I really liked the culture of teaching and the culture of kind of like teamwork that was a part of internal medicine more so than any other special or specialty. So for me, the learning aspect of it, the kind of the structure of it, where you have a like a chief complaint, you have a workup, all that kind of good stuff. And then I love physiology. So I think internal medicine, it's truly you have to understand the physiology to solve something. So I think the combination of physiology, the culture, teaching, and working in a great team setting is why I chose internal medicine.
The next question is, so it seems like you each have a very specific interest in internal medicine. Dr. Imran with cardiology, and then each of Dala and Yusuf, you both have specific fellowships you want to apply to. So why did you pick those specific specialties? Dr. Imran, why don't you get us started again for this one?
Great. So I think for me, it was a combination of the intellectual side of things, but also being hands-on. I enjoy seeing patients, and having that continuity, but I also like to be able to fix the problem right away, which is, one of the aspects of cardiology. We're dealing with a lot of acute cardiac issues, acute concerns where, if we need to take a patient to the cath lab, if we need to do urgent procedure, we can do that. At the same time, we also have the opportunity to develop that relationship with our patients. That's important in the longitudinal setting. See them in follow-up and prevention, both primary and secondary prevention, and have the opportunity to build those relationships. So I think it was actually really a combination of all of those. One thing I will say that, I thought I would never use, that we all go through, in college and medical school, we all go through physics. And then I was always wondering, why do I need to, take physics? We never used physics in the rest of medicine until I got to cardiology, because I run the cardiac MRI program at the VA, so I do a lot of advanced cardiac imaging as well. So MRI physics, which we're always teaching, and we're teaching our fellows and students are there. And then we have physics with nuclear medicine, so we do nuclear stress tests, and then we have ultrasound physics with echocardiography. So it's the culture of learning, teaching, and really a specialty that incorporates all of those, and is just evolving, is what drew me to cardiology.
I guess we'll keep the same order for the questions. I During my first year of residency, so as an intern, I spent a lot of time on GI services, both like our main, we have like a specialty GI service that we rotate through, as well as like a couple of different consult blocks that I did on GI. So I felt like probably that heavy exposure up front made me more interested in the field. But personally, I really like the management of IBD, which is probably what I'm going to focus on once I'm done like with training, inshallah. Um, I'm really excited about like a lot of the new advances, like in terms of new biologics that are coming out. And generally for a lot of patients with IBD, they're young and relatively otherwise healthy. And so I think it's very life-changing if you're able to kind of develop those relationships with these patients and help them like achieve clinical remission to try to lead a bit more of a normal life, just because it is such a debilitating condition. So yeah, that's something that I feel like has really drawn me to GI. I do like the procedural aspect, but I'm not so like heavy in terms of like enjoying procedures. So I don't think that that'll be the main focus. But I think it is nice, kind of to have a clinical side of our work and engage with patients that way, but also to kind of have a research focus, which is something that I'm really passionate about with my research. So yeah, I think that's probably a couple of different reasons why I want to go into GI.
Yeah, I think for me, I think Dr. Imran kind of touched on all the great things. I think cardiology is the greatest field of medicine, and Dala should probably kind of consider going from GI to cardiology. But I think for me, what I really liked about it is that there's both the opportunity to get so much information from a non-invasive, if you don't like procedures, to obviously if you want to go in the cath lab and do things, there to being a very strong proceduralist. For me personally, I love the fact that I can go bedside, throw an ultrasound on a patient and get so much information just from a focus of their heart. So for me, being able to get non-invasive information really quickly, is was really cool to see, especially as a medical student and then as an intern in the second year. The amount of kind of decisions you can make like right then and there really is really cool to see. Um, Besides that, I mean, at the end of the day, the heart is kind of like the king of all the organs, is what I like to say. I just got off a nephro rotation. I told my nephro attendings that you have two kidneys, you only have one heart, so the heart wins every time. So no, I mean it's a really cool field. It's got a lot of amazing pathophysiology, so that's kind of why I went into it.
Okay, so our next question, which is great because we have both attending and residents here, is what does a typical day in the life look like for you?
So for me, every day is different. So I'm actually, my position is unique because, so even though I'm part of Brown, it's an academic institution, I work at two different hospitals. So I work at a VA, and I also work at the Rhode Island Hospital, which is the academic teaching hospital. The VA also being affiliated with Brown. And so it's sort of like having two different jobs. But each of them is unique. And so I do a lot of advanced imaging. I run the cardiac MRI program over at the Province VA. I also read echocardiograms and nuclear stress tests. And during all of these, and do transesophageal echoes, so some procedures there, and cardiac MRI stress tests. And then some days I'm doing clinic, both at the VA and at Lifespan, which is outside the VA. And then I do inpatient consult and cardiology services at each of these hospitals. So the patient populations are quite different in that regard. So, if I'm not in a hospital service week, then I'm going in either my clinic, my imaging, or my research time. So, some people may be interested in research. I'm also involved in research as well, which takes up currently about 40% of my time. So it's actually, I'm kind of in between all three of those at the moment. And I'm running a human subject research study at the VA using advanced imaging. So day to day really varies for me. It's split up between the clinic, the imaging, advanced imaging research, and then if it's a hospital service week, I'm seeing patients in the hospital that entire week. So you could get exposure to a lot of different things, but that's what I truly enjoy. And as part of all of these services, I'm involved in teaching fellows and residents and students. And I think that's one of the highlights of my job as well, being in an academic setting.
So our program is pretty inpatient heavy, and we rotate through a lot of different services. So we have a cardiology service, a GI service that the residents are on, and managing all those primary like GI or cardiac issues, and then all of our patients' other medical issues as well. We also rotate through cardiac ICU, regular medical ICU, as well as a hematology oncology service. When we're not doing those rotations, we have a couple of different like consult rotations that are inpatient. Otherwise, we spend about we have two full months of outpatient clinics, which usually includes our own continuity clinic where you see your own patients, and then subspecialty clinics. So you might go to nephrology, cardiology, rheumatology, endocrinology. So a lot of different fields that you get exposure to, which is nice. So it's kind of hard, like a day in a life, because I feel like it changes so rapidly. Most of our blocks are usually 2 to 4 weeks. The inpatient blocks for seniors tend to be a full 4 weeks. I guess I can talk a little bit about like inpatient rotation and what that looks like. So typically we get to work like around 6 or 6:30, sign outs usually by 7. You like pre-round and see all your patients, and you look at everything in the chart, like their vitals, their labs, any new imaging, so that you're ready to present them on rounds. We usually round from like 8:30 to noon. Then the rest of the day is kind of spent. If you're not admitting that day, you're kind of just working on your notes, getting your patients tucked in, putting in orders, following up on like any kind of prior workup or ordering like new labs if there's kind of a new issue or new imaging, things like that. If you're admitting, then you kind of take admissions the rest of the day, and you're kind of balancing taking new patients and then taking care of your old patients. And then usually sign out is about like 7 or 8 that day. So we're typically working like pretty long days, and our teams, usually there's like 2 first-year residents, a senior resident, and then we generally have like 1 to 2 medical students, as well as our attending. So we're working in really big teams, and we also have care managers and social workers and a lot of different important people who are part of the medical team. So that's kind of what inpatient life looks like. And again, this varies like if you're in an ICU setting versus a floor setting. But that's kind of the gist of how things tend to go.
Yeah, I mean, my schedule's kind of the same as Dallas. I won't kind of repeat much of what she said, but the most important thing for you guys is when you start your day, when you get to the hospital, you got to find all the free food that's up at these hospitals, because every hospital has a secret location. So that's what I do first thing in the morning before I get to start my day, is find the free food, then, sit down, and then like Dallas said, get ready to work.
Yeah, as a medical student, I'll definitely second that. You have to get something for your time at the hospital. So our next question is from the audience. And it's, what are the main differences between inpatient and outpatient internal medicine? And what are the deciding factors when you're choosing a career path between the two?
I think it mainly this comes with experience, but the main difference I'd say is really the acuity of how ill the patients are. So there are different inpatient services as well. So you have patients who are on a regular floor, then you have patients who may be in a hospital in a step-down unit. They tend to be sicker, and then you have the sickest patients who are in the ICUs. So this could be medical ICU or the cardiac CCU units. So those are patients who are critically ill. And outpatients usually tend to be the more stable patients who are coming for their routine follow-ups, but you may also have urgent care clinics where there may be patients that are less stable, and then your job is to kind of figure out, to triage them where they would go, whether they need to go into the hospital or et cetera. So the difference in practice really, would be what you're managing conditions in the outpatient setting. Actually, all areas of medicine, and especially primary care, internal medicine, the focus should really be on prevention, both primary and secondary prevention of the chronic conditions, and also treating the patient's chronic conditions and trying to keep them out of the hospital. In the inpatient setting, of course, the focus is, what their acute illness is and what you're treating in that time, but you do want to transition them safely to the outpatient setting. I don't know if that was what the question was alluding to, but those are the main differences.
I think some other things to think about, I think part of the question was in terms of like choosing a career. So there are, physicians who, primarily mostly just do inpatient medicine. They split their time sometimes between like being heavily involved in research and then the rest of their time just rounding on inpatient services, and they don't see any patients in the outpatient setting. So that's a choice that some people make. And then for a lot of primary care physicians, for example, their job is solely outpatient. So they're only seeing patients in a clinic. They're not rounding in the hospital at all. I think majority, at least for a lot of my attendings, they kind of split their time more heavily on the outpatient side, and then a couple, some people do like 8 to 10 weeks a year where they're on the inpatient side and rounding with a team. Some people do a little bit more. Some people kind of split their time between inpatient and outpatient. So I think it kind of depends on the medicine that you enjoy. Personally, it's not that I don't like outpatient management, but I feel like things generally move much more slowly. And I kind of like on the inpatient side that you can get answers much more quickly, you can do workups much more quickly. So I kind of like knowing things, like my personality. I just like to know things more soon, sooner rather than wait. And sometimes you can kind of see the results of your work much sooner, like on the inpatient setting. Sometimes outpatient, it is still rewarding, like when you're working with patients for months. Let's say I'm seeing one of my patients for hypertension, and we're kind of working to better control their blood pressures. It definitely is rewarding, but a lot of times that may take several months or sometimes even years, like if patients are not coming into the office as often, or having other issues that kind of preclude them from getting more consistent care. So there are definitely challenges with both inpatient and outpatient medicine. I think generally, like during med school and residency, people have a pretty good sense as to what they enjoy and what they prefer. So
Yeah, just to echo what they both said, I think the hardest part is that, when I came into residency, I thought I would love clinic and I would, I loved inpatient medicine, but I thought, I'd always be a clinic guy. And then after I got into residency, I realized that clinic to me is more stressful than the ICU. So, you just got to kind of figure out what you like, what you enjoy. Inpatient medicine, things happen fast, right? So, you have a clinical suspicion, you think your patient's in heart failure, you can focus them, X-ray, EKG, all that stuff happens fast. In the clinic, it takes time, things are slower, you might have to follow up. So it just depends on what you like. And what's kind of nice is, and I think Dr. Imran can probably speak to this, because she has more experience, but as you kind of become an attending and get farther along in your training, you have the option to kind of mix and match and balance it how you like. So if you want to do like more inpatient with a little bit of clinic, you can do that. So you have a little bit more flexibility as you figure out what you enjoy, but kind of residency, I think, and fellowship is that time to kind of like figure out what exactly you like and how you want to kind of spend your life practicing medicine.
For everyone who just joined, if you have specific questions for the panelists you would like me to ask, you can message me. We'll also have a little bit of time at the end for breakout rooms if you prefer to ask then. The next question we have is, what does a research project in internal medicine typically look like?
So that's a good question. It depends on the type of research you're involved in. So there are different areas of research, and then there are some people, two main areas. There are some people who've been involved in basic science research from their years before medicine, and they've actually continued that throughout residency and fellowship and beyond. And then that's not very common, but then most people are interested in clinical research or translational research, and there could be different types of research projects in that. So there is an area of epidemiological research where you can look at, to answer a clinical question, you can look at cohorts and of databases that are already available. There's another area, obviously, the topmost, the best study you can do to answer a clinical question would be a randomized trial. And that's usually done at a multi-center level. This could involve human subject research. This is something that you could be involved in as part of your center. Other options would be translational type of research, where there's research that's being done in the basic science realm, and then we're trying to translate that to human subjects. So those are all different areas of research. And if you're in an academic institution, it's very likely that those types of research are going on at your institution. If you are interested in doing research during training, usually most people tend to go with clinical research where they can be involved in a research study that's ongoing. In addition to that, you can also be involved in writing up a clinical case that's interesting, or submitting an image to a journal that's interesting. Those are other types of clinical areas of research that you can be involved in. But it depends on what your ultimate goal is and whether you'd like to pursue research as part of your career. And I'm also happy to talk to anybody. Feel free to reach out to me if they're interested in research in particular and want to know how to incorporate that into their career.
And then we have one more panelist who just joined. Malik, if you want to introduce yourself.
Hey, salams everyone. My name is Malik. Actually, I just graduated, so I haven't really started residency, but inshallah, I'll be starting at Henry Ford for internal medicine this year. So glad to be here.
Thank you. And if any of the other panelists have anything to add about what research looks like in internal medicine.
I was probably just going to say that a lot of times, like for me and my co-residents who are doing research, we usually start by kind of asking ourselves, like if it helps to know, especially early on, like which fellowship you're interested in doing. And I think if there is like a particular interest that you have, like in a subspecialty of the field that you want to go into, then finding a mentor who does work in that area is really helpful. So my research mentor focuses like all his research on IBD outcomes. So getting plugged in with the right people, I think, is really important, and kind of figuring out like, what kind of ongoing projects they have, or being generally like at least at our institution, a lot of the faculty is very open to hearing new ideas. So if you want to pitch something to them about what you're interested in looking at more, they're generally happy to do so. But generally for faculty who are very research heavy, they do have a lot of ongoing projects, and they're happy for residents to join. And once you come up with like a clinical question that you're trying to answer and come up with a proposal with their guidance, then generally it's tough doing research as a resident. It does require a lot of extra time and energy and effort. But I think kind of relying on your mentor and just going in with an open mind, but kind of going in knowing what you're interested in and finding the right people to work with would be like my practical advice, at least, for how to go about research opportunities.
Yeah, just quickly to kind of echo what Dala was saying. I think, obviously cards, GI, HEMONC, these are going to be kind of like your more competitive research heavy, fellowship applications. And the more, publications and everything you have, the more competitive you are. So I think the hard part with research and residency is the earlier you can find mentors and research, the better off you are. So that's kind of like the hard part about residency, because, Dal and I are going to be applying. I think the application opens tomorrow if it hasn't already opened, but you basically have like a year and a half to kind of like cement some good research before you start applying. So that's like the tough part in residency, I think. But luckily, if you have good mentors and they're productive, they can help you out.
Also, if like this question was just in regards to like landing like a spot in IM at more like of an academic place, I feel like what field, like you can just get a preliminary understanding of what field you might be interested in, just do research in that field, or just do research in any IM related field, and it should help you out regardless.
And our next question, I think, Malik, you should start with this one because you applied most recently, is what advice do you have for medical students who want to apply into internal medicine? Like what sort of things should they focus on?
I think just showing that you have like an interest in internal medicine, I think, is a big deal. A lot of I don't know, a lot of the people on the interview trail personally just asked me like what I was interested in. If you have like a vision of where you're going to go with the training that you get as an internal medicine resident, whether that's specialization or you know, general practice, whatever it is. I feel like if you have a good vision, have a good story, I think that really matters a lot. Obviously, scores and research and all this other stuff also matters quite a bit. And then geography too, like if you have a good reason to be at a certain institution, just the general kind of things that would help somebody match into a specific program. But for internal medicine, I found just a lot of sorry about that. Internal medicine, just, you know, interest and vision, I think, was really something that came up a lot on my interview trail. And obviously scores and research also help a lot too. So yeah, that's I think that was some of the most important stuff, at least.
Okay, so our last question before we can do breakout rooms for the last 20 minutes will be, what advice do you have for yourself as a medical student? If you could go back and tell yourself something, what would you tell yourself?
That's a great question. So I think if I could go back, I would tell myself to stress less. That's the first thing. You know, I would also, it's one thing that I realize it's challenging to have an opportunity to really explore all the specialties that are available. So, you know, I would say, you know, if there are other areas that you think you might be interested in, but you don't have that much exposure to reach out early, even just for shadowing experiences, to get a variety of exposure earlier on and throughout your time as a medical student. Because unfortunately, a lot of the decision making regarding specialties and subspecialties tends to occur early on. I think for me, you know, I mean, in the end, it turned out okay. I always knew that I liked cardiology since I was a medical student, but then it wasn't until later on in medicine residency that I really decided that that's what I was going to pursue for various reasons. And I think part of that had to do with not enough exposure during medical school, even in terms of being involved, you know, both in the clinical setting with doing electives and research. So there's nothing wrong with you know, doing research or being involved in one area and then changing your mind. But it's good to have that exposure early so that you can make an informed decision and don't feel that you have to be rushed. Because ultimately, you know, you want to make the decision that is the right decision for you. It's something that you enjoy doing because that's what you're going to be doing for years to come.
I would probably say two things. I think it's important, you know, as a medical student to figure out what you want to do in the future, and like obviously, you know, kind of think about like how you're going to reach that goal. But I would say like try to enjoy all your other rotations, because that might be the only time that you may get as much exposure to a certain field as you do. And you may not ever, you know, get to take care of, for example, like OB patients. So I would say, you know, try to at least, even if there's something that you don't end up liking as much as you're going through rotations, like to still try to enjoy the experience as best as possible and to try to learn as much. As an internal medicine resident now, like I definitely still recall things from when I was on my psychiatry rotation, for example, that are helpful. So just, you know, trying to at least be open-minded and kind of value the different experiences that you're getting, even if it's something that you're not going to really ever do in the future. My other advice is to really like cherish the time that you're able to spend with your patients as a medical student, because the further out you get in your training, like especially as a resident, we definitely try our best to like spend time talking with patients and their families and things like that. But I feel like with kind of the workloads that we have and all the charting that we do, it definitely eats up like a lot of the day. So I would just say, like, try not only to learn from your patients, like from a medical sense, but also as people, and to just kind of connect a little bit more with like their day-to-day struggles. Cause I feel like sometimes as physicians, we're a little bit out of touch with like how, you know, people who are not in medicine, like think about things, and it really can help like in the future if you've connected more with people that way, like to know how to approach them and explain things to them. So that would kind of be my advice.
Yeah, I think for me personally, you know, one piece of advice I'd probably give myself as a med student is that, you know, just continue to have fun in medicine. Medicine is a lot of fun, you know. It's fun to learning is fun, but working, you know, kind of sucks. So when you get to residency, you'll have to find that right balance of working and learning, but you can still have a lot of fun, you know, in residency, even though you're going to be working a lot. And so, for example, like I said, I love the team aspect of internal medicine, and to make things fun for my co-residents, my interns, my medical students, I have a little rounding stick. And so when we go around, we round with a rounding stick. And it's kind of funny because I got that at the VA, and all my veterans have their own rounding sticks. So when we get to the patient's room, we often compare sticks and see whose stick is better. But just small things like that really make the difference. And then secondly, you know, this is something that's kind of like more so when you're like applying into residency, that I think is a very tough decision. But if you do know that you want to go to some or do something competitive like GI, cardiology, hemonc, whatever it is, obviously looking at programs that match well is important, but you have to kind of balance that with other things in your life, like, you know, being close to family. So for example, I was born and raised in Michigan, went to Michigan for undergrad, went to Wayne State, Henry Ford for my rotations, and then I'm at Baylor right now for residency, and it's a fantastic program, but you know, I'm really far away from family. So that's been the hardest part for me for residency, has been being away from my loved ones. So that's kind of like something that you guys got to balance. And, you know, obviously at the end of the day, you can always come back, but residency is a very tough and stressful point of your life. So just kind of when you get to that point, take all that into consideration.
Okay, so thank you for answering all our questions. I want to give enough time for breakout rooms. I'm sorry to everyone who direct messaged me questions. If you're able to, you can ask in the breakout rooms. I made a breakout room for each panelist, and that way you can pick where you want to go. I'll open them now, and then I've assigned each of our panelists to a breakout room. So our participants can kind of move around however. You should be able to choose a room to join. If anyone has any issues, you can message me.